Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. A 34-year-old woman arrives in the emergency department. She's agitated, trembling. Her muscles are rigid. Her temperature is 39.8 degrees and climbing. The ER team is baffled. She's not septic. She has no history of seizures. There's no obvious overdose. She looks like she's falling apart from the inside. 2 days earlier, her GP added a new medication to her existing antidepressant. A routine prescription. Unremarkable on paper, but that combination is killing her. Today we're breaking down one of the most underdiagnosed, most preventable, and most dangerous drug emergencies in clinical medicine: serotonin syndrome. By the end, you'll understand exactly why it happens, what it looks like at the molecular level, how to recognize it, and what doctors do about it. Before we get into what goes wrong, we need to understand what serotonin, chemically known as 5-hydroxytryptamine, or 5-HT, actually does when everything is working correctly. About 90% of the body's serotonin is made in the gut, where it drives intestinal movement. Around 8% is stored in platelets, contributing to vessel constriction and clotting. The remaining fraction is made in the brain, and it's that fraction that does the most pharmacologically interesting work. In the central nervous system, serotonin regulates mood, sleep, appetite, cognition, and body temperature. Serotonin acts on at least 14 known receptor subtypes. For this topic, the two that matter most are the 5-HT1A and 5-HT2A receptors. The system is tightly regulated. Serotonin is released and binds to its targets to trigger responses. It is then removed from the synaptic cleft by a transport protein called the serotonin transporter, or SERT. Once serotonin reaches the presynaptic terminal, enzymes called monoamine oxidase break it down and recycle it. It's an elegant feedback loop. And every single step of it is a drug target. Serotonin syndrome doesn't require an overdose. It doesn't even require a mistake in the traditional sense. It is almost always the result of multiple serotonergic agents acting simultaneously, each one pushing synaptic serotonin higher than the system can handle. Let's go through the major drug classes by mechanism. First are the reuptake inhibitors. These are the most commonly prescribed. Selective serotonin reuptake inhibitors, or SSRI, like fluoxetine and sertraline. Serotonin norepinephrine reuptake inhibitors, or SNRI, like venlafaxine and duloxetine. And older tricyclic antidepressants all block SERT to varying degrees. Less serotonin gets cleared, so concentrations in the synapse rise. Then, there are the monoamine oxidase inhibitors. Examples include phenelzyme, tranylcypromine, and the irreversible selegiline. These drugs block the enzyme that degrades serotonin after reuptake. Less breakdown means serotonin accumulates further. The combination of an MAO inhibitor with an SSRI is one of the most dangerous drug interactions in all of pharmacology. It has killed people. And it still happens. Often because the two prescribers involved have no idea what the other has prescribed. Some drugs force serotonin out of the presynaptic terminal regardless of normal signaling. Methylphenidioxymethamphetamine, or MDMA, is the classic example. Tramadol is a subtler one, and one that is routinely overlooked. And then, there are the direct receptor agonists. Triptans, used for migraines, are partial agonists at 5-HT1B and 5-HT1D receptors. Lithium, used in bipolar disorder, increases both serotonin release and receptor sensitivity. Each one adds to the serotonergic load. And last but not least, this is where it gets clinically dangerous: the sleeper culprits. Many drugs prescribed for entirely non-psychiatric reasons carry serotonergic activity that most clinicians simply don't think about. These are some examples. Tramadol is an opioid analgesic that also blocks serotonin and noradrenaline reuptake. Linezolid is an antibiotic that is also a reversible MAO inhibitor. Methylene blue, used in methemoglobinemia, is a potent MAO inhibitor. Fentanyl causes weak serotonin reuptake inhibition, but relevant at high doses. St. John's wort is a widely used herbal supplement that inhibits SERT. And dextromethorphan, the cough suppressant in dozens of over-the-counter cold medicines, is also a serotonin releaser. So, what mechanistically tips the system from therapeutic to toxic? The core event in serotonin syndrome is excess stimulation of serotonin receptors, particularly 5-HT2A, across both the central and peripheral nervous system. When serotonin concentrations exceed the system's normal range, receptors that are rarely fully activated under normal conditions become persistently switched on. The 5-HT2A receptor is a GQ-coupled receptor. When chronically overstimulated, its downstream signaling activates phospholipase C, which drives up intracellular calcium. In neurons, this manifests as pathological rhythmic discharges, the muscle clonus and hyperreflexia you see at the bedside. And then there's also the autonomic instability, the wild swings in heart rate, blood pressure, and core temperature. This is where the mechanism gets genuinely interesting, because it happens in two places at once, through the same receptor subtype, producing two completely different kinds of damage. The first location is the raphe nuclei, the brainstem's serotonin factories. Dotting the surface of every raphe neuron are 5-HT1A autoreceptors. These are presynaptic. They sit on the very neuron that just released the serotonin. Their job is to sense rising serotonin levels and signal the neuron to slow down. It is an elegant self-governing brake. When serotonin rises too high, the autoreceptor fires, activates GIO, hyperpolarizes the neuron, and cuts output. The system corrects itself. In serotonin syndrome, that brake is overwhelmed. Serotonin concentrations are so high, driven simultaneously by blocked reuptake and inhibited breakdown, that the autoreceptors saturate. They can no longer signal proportionally. The GIO feedback loop collapses. The raphe neuron keeps firing without restraint, flooding its downstream targets with wave after wave of unregulated serotonin. The second location is the hypothalamus, the brain's thermostat and autonomic command center. Hypothalamic neurons carry their own 5-HT1A receptors, but these are postsynaptic. They are there to receive serotonergic input and translate it into stable autonomic tone, maintaining a steady heart rate, a consistent blood pressure, and a calibrated body temperature. When the serotonin flood arrives, partly from the uncontrolled raphe, and partly from the direct accumulation of serotonin throughout the system, these postsynaptic hypothalamic receptors are also overwhelmed. GIO activation silences the very hypothalamic neurons responsible for thermoregulatory control. The set point disappears. Autonomic output becomes erratic. So, autonomic destabilization is not a single event. It is two receptor populations, at two anatomical locations, both hit simultaneously by the same serotonin excess. One losing its brake, the other losing its signal. At both locations, the receptor works through the same GIO pathway, suppressing cyclic AMP, opening potassium channels, and reducing calcium entry. But what that silencing does depends entirely on where it happens. The result is not a clean sympathetic surge. It is chaos. And it is that chaos, expressed as uncontrolled muscle contraction and collapsing thermoregulation, that generates the hyperthermia that kills. The fever in serotonin syndrome is not like an ordinary fever. It isn't driven by cytokines or immune activation. It is mechanical heat, produced by continuous, uncontrolled skeletal muscle contraction. When virtually all your skeletal muscles are contracting simultaneously, they generate enormous heat. The body's cooling mechanisms cannot keep pace. Once core temperature exceeds 41 degrees Celsius, a cascade begins that is very hard to reverse. Rhabdomyolysis happens. Muscles break down, flooding the blood with myoglobin. Then, there's acute kidney injury. Myoglobin precipitates in the renal tubules, blocking them and causing direct toxicity. Disseminated intravascular coagulation happens as the clotting cascade destabilizes. There's also metabolic acidosis, which happens because lactate accumulates from anaerobic muscle activity. And finally, multi-organ failure. This is not a slow deterioration. In severe cases, the progression from agitation to organ failure can unfold in a matter of hours. Serotonin syndrome is classically described as a clinical triad. First is neuromuscular abnormalities. This manifests as clonus, hyperreflexia, tremor, and myoclonus. And then there's autonomic instability. Clinical manifestations include tachycardia, sweating, hyperthermia, hypertension, and rapid breathing. And the third is altered mental status, including agitation, confusion, and restlessness. The problem is that the full triad isn't always present, especially in early or mild cases. That's why the Hunter criteria is now preferred. Developed by Dunkley and colleagues, the Hunter criteria require two things: documented exposure to a serotonergic agent and at least one of the following findings. The criteria place particular weight on clonus, especially inducible clonus. While clonus is not unique to serotonin syndrome in a patient with known serotonergic drug exposure, it is the most mechanistically direct sign you can elicit. A visible readout of 5-HT2A hyperactivation at the spinal cord level. That combination of sign plus context is what gives the Hunter criteria their diagnostic power. Serotonin syndrome exists on a spectrum. At the mild end, a patient might simply feel anxious, have a slightly elevated heart rate, and develop diarrhea after a medication change. These symptoms are routinely attributed to anxiety, a viral illness, or the expected side effects of starting something new. At the severe end sits the picture we described at the opening: hyperthermia, rigidity, rhabdomyolysis, and organ failure. Here's the critical point. Mild serotonin syndrome is common and routinely missed. It becomes severe when the serotonergic stimulus is not removed, when the drugs are continued, or when another agent is added on top. The management of serotonin syndrome follows a clear hierarchy of priority. First is to stop all serotonergic agents immediately. In a patient on multiple medications, this means a systematic review of the entire drug list: prescribed, over-the-counter, and herbal. Everything serotonergic must come off. And then supportive care. Mild to moderate cases often resolve within 24 hours of stopping the offending drugs, with supportive management including intravenous fluids, supplemental oxygen, cardiac monitoring, and benzodiazepines. Benzodiazepines are genuinely useful here. They reduce CNS excitability and dampen the muscle hyperactivity that generates heat. Sometimes, cyproheptadine, a first-generation antihistamine that also antagonizes 5-HT2A, is used. Basically, a specific pharmacological antidote for serotonin syndrome. It isn't available everywhere, has no intravenous formulation, and the supporting evidence is largely observational. But it is widely used in moderate to severe cases. And lastly, aggressive intervention for severe cases. When temperature climbs above 41 degrees Celsius, rapid physical cooling becomes the priority. Ice packs to the axilla and groin, cooling blankets, and in the most severe cases, neuromuscular paralysis with intubation. Paralysis halts the muscle contractions, cuts off the heat source, and allows temperature to fall. One important pitfall. Serotonin syndrome is frequently confused with neuroleptic malignant syndrome, which is caused by dopamine antagonists and looks similar on the surface. The treatments are different, and giving the wrong one matters. The quickest bedside separator is reflexes. Hyperreflexia and clonus point to serotonin syndrome, while lead pipe rigidity with normal reflexes points to neuroleptic malignant syndrome. Back to the woman we met at the start. She survived. Her GP had added tramadol for lower back pain, without knowing she was already taking sertraline. 2 serotonergic drugs. One outcome that should never have occurred. Here's what to take away. Serotonin syndrome is a drug interaction emergency, not an overdose. It happens at therapeutic doses. It is driven by excess serotonergic activity, almost always from multiple drugs hitting the same system at once. What kills is hyperthermia from uncontrolled muscle contraction. That is what leads to organ failure. It exists on a spectrum. Mild cases are missed every day. They become severe cases when the drugs aren't stopped. Use the Hunter criteria. Look for clonus. Ask about medication changes in the past 48 hours. Treat by removing the cause, cooling the patient, and using benzodiazepines and cyproheptadine where appropriate. The gap in prescriber awareness is a systems problem. Medication reconciliation saves lives. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.